Welcome, everyone, and thank you so much for joining us for your COVID-19 Questions Answered, which is our new three-part speaker series. I can see that a lot of you are logging on right now, so we're just getting started. Today in part one, we'll focus on testing, how it works, why it matters, and how to do it right. I'm Judy Fortin, Executive Director of Communications at UCLA Health. As a former CNN journalist, I am delighted to moderate this panel today, and we have three esteemed guests who are joining us to answer your questions about COVID-19. Dr. Kelsey Martin is Dean of the David Geffen School of Medicine at UCLA and the Gerald S. Levy, MD, Endowed Chair. Dr. Judith Currier, Division Chief of Infectious Diseases at the David Geffen School of Medicine at UCLA, and Dr. Omai Garner, Director of Clinical Microbiology at UCLA Health. So just a few ground rules as we get started and more people join us. By the way, we're close to 300 people joining us today. The chat function is turned off. Participant audio is muted so that we can hear our panelists and get right to the questions that were submitted. So let's get started. So I'll begin with the same question for each of our three panelists who bring such unique perspectives as leaders in science and medicine. And here's the question. In these challenging times, what new opportunities have emerged for shaping the future of healthcare? And Dr. Martin, I'll start with you first. Good morning.
Hi, thank you, Judy, and welcome to everybody. Thank you for joining us. So what the COVID-19 pandemic has really illustrated is how effectively and rapidly we can come together as a community of physicians and scientists. It's really a momentous challenge, a momentous time for academic medicine. And at UCLA, I consider it our calling to care for patients and to develop the new and effective diagnostics, therapeutics, and cures. And in this moment, to develop those strategies to approach the COVID-19 pandemic. I've seen our physicians and our researchers come together in a way that I've never seen before. To develop novel approaches for COVID-19. We've collaborative teams have developed across not just the school, but across our entire campus to start clinical trials in record time, something that Dr. Currier has been essentially involved in, to undertake basic science and translational research projects to understand how the SARS-CoV-2 virus infects cells, how it causes disease, and to get COVID-19 testing off the ground and available for our patients. And that's something that Dr. Garner has really been at the heart of. The silver lining of this, of the COVID-19 pandemic is that it's shown all of us how sort of the amazing and impactful fruition of seeing scientists and physician scientists come together at UCLA, across our nation, across the globe to collectively develop new tests, new therapies, and new cures.
Thank you, Dr. Martin. Dr. Currier is head of infectious diseases at UCLA Health. What new opportunities have you seen emerging in the future of healthcare?
Thank you very much, and thank you for including me in this panel today. You know, it's been said that in every crisis, the seeds of opportunity can arise, and this has really been exactly what's happened with COVID-19. From my purview as the Chief of Infectious Diseases, I've seen this in both the clinical arena and in the research arena. Our division had to organize itself to provide clinical care and to get studies up and running. And I think that it's been all hands on deck for the past couple of months. And we've seen many, getting clinical trials going is a process that involves multiple departments across UCLA, and everything's been done in parallel. And these roads that have been paved to rapidly open trials, I hope will remain open when the crisis is over. Secondly, on the clinical side, two observations I would make. The need for multidisciplinary care of COVID patients is really essential, and teams from nursing to medicine across specialties gathering together on a daily basis to make clinical decisions, well, something we always strive for in medicine has really come together in a unique way with COVID. And then finally, the emergence of telemedicine and its place in healthcare has really, I think for many of us, really starting to see the value of this, allowing us to stay connected with our patients without them needing to come to the medical center. And there are times when that's appropriate. And I think that we're finding that people really enjoy the convenience of that and that we're able to stay in touch. So UCLA's facilities for doing telemedicine and video visits have just been extraordinary. And I think that's something we'll see used a lot more in the future.
Very good points. Dr. Garner, you're leading our testing efforts at UCLA Health. I know you're thinking about the future of healthcare. Why don't you tell us about what's on your mind this morning?
Absolutely. So I would like to thank you for allowing me to participate today as well. So, diagnostic testing, it's always been integral to assisting infectious disease diagnosis, but it's always, of course, been in the background. So whether it's been sepsis, HIV, influenza, there are always high quality tests that assist. But creating a new test, a brand new test for a new disease is actually a very long process. So typically it takes years of research and then months of work within clinical laboratories like mine to be able to make this test available, accurate, good for patient usage. COVID-19, as we've seen, has really accelerated this process. So on February 29th, that was the day the FDA allowed clinical laboratories to develop tests. And by March 10th, which was only 11 days later, we actually had a test available at UCLA. So the timeline was very much shrunk within there. And when I think about my own career over the last 10 years, directing the clinical microbiology laboratory, there have been a series of new outbreaks in infectious disease, right? Pandemic flu, followed by Zika virus, followed by the reemergence of measles in California, followed by Candida auris, multi-drug resistant bacteria, and then now COVID-19. So, I really see the future of healthcare is attached to the future of diagnostics, research, and development, and being able to pivot quickly to make new diagnostic tests.
Dr. Garner, thank you so much. Really interesting perspectives as we start off. We have about 440 participants now on this webinar. So let's go ahead and turn our attention to the questions that were submitted in advance. And Dr. Martin, the first question is for you. How did testing begin in the United States and what is the current methodology?
Yeah, so that's actually a remarkably complicated question, and it's something that I know both Dr. Garner and Dr. Currier have experienced firsthand at UCLA Health. So to give you really a brief summary, as you know, the COVID-19 pandemic first emerged in China in December of 2019, and on January 11th, China released the genome of the virus, the sequence of the viral genome. The World Health Organization quickly released sequences that could be used in polymerase chain reaction tests, or PCR tests, which is simply a way, a really beautiful scientific approach for amplifying the nucleic acid of the virus. So very powerful way of detecting viruses in samples from patients. And other countries, England, South Korea, very quickly set up PCR assays within the following 1 to 2 weeks. And then on January 20th, the Center for Disease Control in the US, or the CDC, developed its own test. And it was a really elegant bells and whistles test with multiple internal controls. And that was sent out to a variety of US healthcare centers. And unfortunately, one of the reagents in the test had a contamination, and it was realized that this test was faulty. And that then led the FDA to invoke emergency provisions that allowed the use of the rapid approval of novel developed assays. And we're so lucky at UCLA Health that Dr. Garner was here and leading our clinical microbiology lab. And so, as he mentioned, he and his team were able to very quickly validate one of these tests and make it available for all of our patients. And this was really one of the first tests that was available in Southern California. And I think when Dr. Garner talks about this acceleration of the development of this assay, what's really remarkable to me is that is the passion of all the people in his group and his leadership who really came together, working around the clock, recognizing how critical this was for us to be able to address the pandemic in Los Angeles. The test uses a nasopharyngeal swab, so it has to be to collect the sample. So it's something that has to be done by a skilled healthcare worker. And I have to say, you know, again, it fills me with sort of with pride, but also just feels uplifting that our lab was able to go from about 30 tests a day to now around 1,000 tests a day. Again, you know, not just the quick development, but also the quick scaling up of that diagnostic test.
Dr. Martin, thank you. Dr. Garner, a question for you. What is the difference between COVID-19 diagnostic testing and antibody testing?
For sure, you know, that's a great question. So we really have two different types of tests around COVID-19. The first test really looks for the virus. And this is the test in acute infection and typically in symptomatic acute infection. And as Dr. Martin laid out, this is a test that's called a PCR test. And the way this test works is at a collection site, a nasopharyngeal swab is collected from the patient. And then that collection actually gets moved to a centralized laboratory, like my lab at UCLA. And then the test itself actually is divided up into two processes. The first process extracts the viral RNA or nucleic acid out of the sample. And the second process is that PCR that Dr. Martin was talking about, which is a exquisitely sensitive way of recognizing whether any of the COVID-19 viral RNA is inside that specimen. And if it is, then it's called a positive. So that's the acute disease diagnosis test. And then now there's a test for antibodies. And so an antibody test looks for antibodies in the blood. So this is a blood test. And antibodies occur after viral infection. And they're the sign that the immune system has encountered or fought a virus. So the way that this test works is blood is drawn and then again sent to a centralized laboratory. And then within that centralized laboratory, it's tested to look for antibodies that are specific for COVID-19.
Very good. Dr. Currier, did you want to add anything? The question was the difference between the COVID-19 diagnostic testing and antibody testing.
Yeah, thanks. I think one thing to add about the test is the first test is this nasopharyngeal swab, which requires a very special kind of swab, and it's put far back into the nose. Anyone who's had one will know how uncomfortable that is. And it makes people cough. And so when you cough, you can spread the virus. So it's required to be able to do the test. It's not only having a test and a lab that can do it, but the equipment to protect people who are collecting the test. So I think some of our limitations in testing have been this whole chain of activity, not only having a lab that can measure the test, but the personal protective equipment that the healthcare workers need in order to be able to do the test and deliver it to large numbers of people. So there's a lot of work going on for alternative ways of making the diagnostic test, using oral swabs or saliva and other things that will hopefully allow us to test people without requiring quite so much in terms of the personal protective equipment.
Dr. Garner, you alluded to how challenging it may have been to scale up to the demand. How are you doing now? How many people are you testing a day? And do you feel like you have everything that you need?
You know, I've really been proud of our laboratory. Dr. Martin mentioned this as well. So just to give a little bit of background, my laboratory has 120 laboratorians, technicians, and technologists that are working. And since the beginning of this crisis, they have been putting in overtime and really putting in as much effort as possible to bring up testing in the laboratory. So we moved from being able to do 30 tests a day to a capacity around 1,500 tests a day now. And just to kind of give a scale, if we were doing 1,500 tests a day at COVID-19, that's far more tests than I do for any other disease on a daily basis in the entirety of my laboratory. And, you know, I do think it needs to be emphasized how complicated this test is. So this test is high complexity. It requires licensed medical technologists, master's degree in diagnostic science to be able to perform this level of testing. So, you know, I really have to acknowledge all of their work in being able to bring up the level of testing that we can have for our patients at UCLA.
So, Dr. Currier, just want to add a note on testing as well. You know, we've heard a lot about testing delays in LA County, how to ensure availability and equity for all. Are tests available for everyone who needs one?
Yeah, that's a great question. And I think, you know, as we look back on this pandemic, this has been a fundamental issue since the beginning. We have not been able to test as many people as we should. The way, you know, the fundamental way that you control an infectious agent in the community is you identify the people who have it and isolate them and cut and reduce the tracing to their contacts so that it doesn't spread. So efforts have been, you know, really a lot of work's gone into expanding testing, and now LA County has multiple testing sites that are up and running. But I think if you look at the amount of testing that we're doing versus what we ultimately need to do, we still have to keep pushing to make testing more expanded. That's really going to be essential going down into the future.
Yeah, well, the future's here now. We're hearing a lot already about, you know, from the governor and from the mayor about reopening. So, Dr. Martin, I really would love to get your perspective as Dean of the School of Medicine. We've had so many inquiries about social reentry and what role testing will play as the government officials, the business leaders like yourself, reopen. So, how are we going to do this? How are you going to do this?
Oh, great question. So that's, you know, that's something we're paying a lot of attention to is, you know, we've ramped down very quickly. We've moved all our education to remote education. We've decreased the density on our campus. And now we're really looking at how do we ramp up? And, you know, until we have an effective vaccine or therapeutic, testing needs to play an absolutely central role. We need to know who's infectious and hence who's infected and hence infectious. And who isn't. And that's really going to provide a way for us to reopen our communities, our schools, our businesses. There are a lot of challenges ahead for large-scale testing. How are the samples going to be collected? You heard a little bit about the nasopharyngeal swabs, and it is something that you will not forget if you've had one before, and it's not an easy thing to do. So how are we going to collect samples for that? Should we be doing PCR testing? Should we be doing serologic testing? There are a variety of different tests that we also just heard about. There are so many innovative and powerful collaborations going on now between public health workers, between epidemiologists, infectious disease doctors, engineers, to really understand how we can come up with the most effective and accessible COVID-19 tests that are sensitive and specific and that can be done quickly and inexpensively. That's another part that's going to be important for us to really scale this out. This kind of innovation is, in my mind, it provides the first important route to getting our society and our economy back on its feet. So we still don't have all the answers, but the amount of progress that's being made on all fronts here at UCLA in collaboration with colleagues across the nation, across the globe, really does make me confident that we do have sensitive assays now in the PCR assays, but we're going to get even more sort of less expensive, accessible assays out to our community that's going to enable this kind of community testing that will in turn allow us to reopen those activities that are so essential to our city and to our nation.
So, Dr. Martin, while I have you, let me just ask you a quick follow-up question. When you started the academic school year, I'm sure you never could have imagined where we are today. So you've got a class of fourth-year medical students about to graduate. You've just accepted the first year. Help our participants understand, how do you plan for this? It strikes me how nimble and flexible you need to be in the context of this pandemic.
Yeah, well, I think it's taught all of us that we can be nimble and we can be agile, and it's taught us the importance of being able to respond intelligently and thoughtfully to a changing situation. Frankly, I think that's a lot of what science and medicine is about, right? When one is doing a scientific experiment, you collect data, you pay attention to that data, and you revise your experiment. When you're taking care of a patient, you make you make a diagnosis, you treat, and you see how it responds. So I think that it's part of the practice of everything that we do, but we've now had to scale that out to our entire community and understand how we as an organization can be nimble and agile in that way. I also think when you ask about, in the context of running a medical school, it certainly is not what I expected last fall. I have been amazed at how the creativity that our faculty and staff have brought to the education of medical students, how much can be done with technology. Here we are, 497 participants on this call, sharing information. We were able to get questions from you and have them inform, help us understand the questions that are out there in our community, and then work together to say, well, how can we answer these effectively? I think that it's also inspired a new generation. I can tell you my daughter is entering medical school next year, and I think as she looks forward to what a career in medicine is going to look like, it really does get to that sense of medicine as a calling. Here's something that is affecting all of humanity and that requires that deep biomedical research and that healthcare to address for the entire globe. And so I do think it's changing the way that we do medicine, that we teach medicine. Dr. Currier talked about telemedicine. So even thinking about, what are novel approaches for using the technologies that have come online to be more impactful and more effective.
Excellent. Well, congratulations, Mom. You've got a smart daughter.
Yeah. Thanks.
Dr. Garner, here's a question. We've actually had a couple versions of this question about the possibility of false positives or false negatives in testing. How prevalent are they? Why does it happen? And how do you know if the test results are accurate? So let's start with what are false positives? What are false negatives? And are they prevalent?
For sure. So, it's a great question. It's something that we think about in diagnostics a lot. I think the reality of diagnostics is nothing is 100% perfect. So we won't have a test that won't have 0 false negatives, meaning somebody's positive, but they got a negative on the test. They have the disease, but the test says they don't have the disease. Or alternatively, a false positive where the test says they have the disease, and then they actually don't have the disease. So as we realize that nothing is perfect, we strive to use the best tests possible. And there are some points I think that are good to make around COVID-19 diagnostics, either false negatives or false positives. So, I think that we can start with the PCR. So this was the test that's used for acute disease diagnosis. There were rumors and actual publications that came out that suggested that the false negative rate on that test was up to 30%. So what that means is if you have 10 people who tested negative for the test, 3 of those people actually are positive. That actually is an unacceptable rate of false negativity for a test, and it's nothing that we would try and use for a clinical diagnosis. As a lab director's perspective, we want to use the best tests possible. And so this really gets down to this idea called sensitivity, and that's how you understand the false negatives that are produced in a test. So when we look at our PCR tests, the first thing we ask is, how sensitive, how analytically sensitive is the test? Meaning, how low amount of virus can the test actually measure? And so when we do that kind of analysis for the PCR tests that we're running, we find that these tests are exquisitely sensitive. They can actually get down to 50 copies of virus per mil of fluid that's been collected. So this is a test that I like to say, if the virus is in the sample, the test is going to find that virus. Now, when we're really thinking about clinical sensitivity and false negatives, we do have to ask the question, is the virus in the sample? And there are a lot of things that go into that. So one thing is, when did you take the test? If you took the test when it was symptomatic, when your patient was symptomatic and you collected the sample at that time, we find that false negatives are actually very, very rare. So in that setting, the test is very good if somebody is symptomatic. We don't know how well the test performs, let's say, in the broader asymptomatic population. And this is why a lot of the suggestions from the physicians are, we focused our testing on a population that is symptomatic. So when we've done an analysis of our own PCR testing, we find our sensitivity to be about 97%. And so only in around 3% of cases are we finding false negatives. And this ends up being an important thing to know about our tests. When our test calls a negative, we are 97% sure that that negative is true. Now, when we move over to the antibody testing, it actually changes to what do we do with a false positive, right? I think Dr. Currier made mention down the line this concept of immunity as related to antibody positivity. But we really want to know if somebody has a positive test result, does that mean they're actually going to be immune to the virus? There are a lot of questions wrapped around that. But one thing we think about in diagnostics is what's our false positive rate? So for the test that we're bringing on at UCLA, the false positive rate is estimated to be around 0.7%, meaning only 7 people in 1,000 would end up having a false positive on that test. That's one solid data point. Unfortunately, when you're thinking about false positives, you also have to think about prevalence of the disease in the community. And this leads to something in diagnostics we call positive predictive value. And the prevalence plus that false positive rate really gives you a better idea as to whether or not the result is a false positive or a true positive. And I'll tell you right now, because antibody testing has just come online, we just don't know yet. And these are the types of things that we need to look at as we bring on the diagnostics.
And that's where Dr. Currier comes in. So Dr. Currier, let's talk a little bit about immunity. Our audience is very curious about if they can contract COVID-19 again if they've had it once. We've heard about herd immunity. What is that? Will this virus ever go away? So let's start with question number 1. What do we know, what do you know about immunity so far with COVID-19?
Yeah, so I would say we don't know as much as we need to know about immunity. We would hope that if somebody develops antibody to the disease, that it would protect them from infection. But what we don't know about this particular infection is how long the immunity lasts, and if so that's one issue. With other types of coronaviruses like the common cold, you can get them again. So I think we need more evidence as to whether immunity is protective and how long it lasts. And hopefully with all the work that's going on, we'll get that. I just want to follow up on this false positive issue, because it's really confusing to people of why could a test be so, why would we have this problem, and the issue of the prevalence of the infection. So if you have a disease that's 4% of the population has, and you have 1,000 people and you have a perfect test that's 100% sensitive, 40 people are going to have a positive test, that it's a real positive. But if the specificity, if there's a 5% false negative rate, then of the 960 people that don't have the disease, 48 are going to get a false positive test. So now you have 88 people that have a positive test, and 40 of them are true positives and 48 are false positives. So when we say immunity, are we saying everybody whose test is positive or everybody who's a true positive? So I think as we try to do this research to understand what the antibody test means in terms of protection, we have to keep these things in mind. So fortunately, the test that Dr. Garner's put in place has a low rate of false negatives, so false positives. So that will help us. But I think we have to recognize that we're at early days here, and we can't take a positive antibody test to the bank and say we're safe to go out into the world without using protection when we come across somebody with COVID.
Dr. Currier, can you talk a little bit about herd immunity? Sweden, for instance, is taking this tactic. I think some of the numbers are just starting to come out. You don't have to talk about Sweden, but help us to understand what that is and whether that's something that might be considered in this country.
So herd immunity, it's an epidemiologic term. It describes a situation where in which a population of people are immune to a disease. And usually herd immunity, we're talking about vaccination immunity. We're not talking about natural immunity. But the idea is that if enough people are protected, if somebody comes along with the infection, they won't be able to spread it it won't spread within the population, and that immunity amongst the broader population will protect those who are vulnerable. We used to talk about that with measles vaccination, that when 90% of people have measles immunity, measles doesn't take off. As people stop vaccinating, we get more susceptible. You can have an infection take hold. The problem with this infection and herd immunity is you would have to infect 60 to 80% of the population with SARS-CoV to get that level of immunity. And if you infected that many people, it would be a disaster. A lot of people would die, hospitals would become overwhelmed. So it's not a strategy for preventing this infection. Only with a vaccine will we have herd immunity for SARS-CoV-2.
May not be the answer that we all wanted to hear, but at least we heard it from the head of our infectious diseases program. Dr. Martin, I'd love for you to refocus the conversation now on what's being done for research at the David Geffen School of Medicine and UCLA Health, and how researchers are responding to the challenges of investigating the diagnostics and potential treatments, and even vaccine if that's a potential here for COVID-19. Where are we? What's happening? What are you excited about?
Yeah. Well, it is a great question. And it is, I listened to Dr. Currier and to Dr. Garner and all the questions that were sent in, and I see there are people putting questions up on the Q&A. And I just do want to say that, while we don't have time to go through all of those questions, we're paying attention to them and we will use them in our communications going forward, because it's so important for us to know what questions are important to our the folks on this call. And really, when I read them, what I think about is how much research we still need, right? So when Dr. Currier talks about herd immunity in the context of immunization and vaccines, we need to get to the point of having a vaccination. Again, how the David Geffen School of Medicine and UCLA have really come together, and I would say they've come together in a manner that is collaborative across institutions, is to put together a very clear organizing infrastructure that will bring the expertise that's needed to address all of these issues, whether it's developing tests where you can have something that's sent to somebody's home and have a sample taken and a sensitive, specific test for the virus done, whether it's identifying the therapeutics that are going to be effective when somebody does come down with SARS-CoV-2, get infected with SARS-CoV-2, or whether it's developing a vaccine. So what we've done is number one, we've instituted a registration process for all of the COVID-19 projects that are ongoing in our school, and it's been remarkable to see the array of diverse approaches that our faculty are taking. We've started a COVID-19 research oversight committee that evaluates projects for funding so that we can use philanthropic and institutional funds to support the highest impact projects. We have a clinical trials task force that Dr. Currier is a lead on, that really helps us get our clinical trials up and running for our UCLA Health patients in truly record time. A basic science task force that's helping us learn more about the virus and the immune response to the virus, taking people who work in, from structural biology to immunology to RNA biology to virology to really understand more about the SARS-CoV-2 virus and the response to it. Those are discoveries that are going to be critical for us to develop an effective approach, not just to this pandemic, but I believe to future pandemics. We have a health equity task force that's trying to understand how COVID-19 differentially affects populations, different communities, and in fact, how we can learn from this pandemic so that we're going to be able to improve health equity going forward. This is a pandemic that doesn't know borders. It infects individuals across communities, and so our approach has to be one that incorporates health equity within it. We have a biospecimens task force because those specimens from patients are so valuable, and we want to make sure that the research that we do on them is of the highest impact and is really going to have contribute to discovering therapeutic approaches and cures. So all of these task forces are focused on facilitating research. They've identified every barrier, every point of friction, and found solutions to those. And so, you know, I think it was Dr. Currier said, you know, we can't let a good crisis go to waste. And so this, again, is a way that we're learning what are the barriers to really making progress on research. And it's allowed us to get these studies started as quickly as possible, to share the information, and to really test a variety of approaches so that we can come up in the testing arena with a test that is going to be accessible, low cost, and effective and sensitive. So I would say, you know, that combined with just the recognition of the extraordinary level of sort of generosity and spirit of service amongst our faculty, staff, trainees, has you know, shown me that what happens when there is a challenge that people come together to confront. I think we don't have all the answers yet. That's part of why it still really is a challenge, but I do believe that there is you know, I am a UCLA optimist that there really is the creativity and the brilliance and the dedication that's going to get us there.
Love that enthusiasm. I'd say it's infectious, but this is probably not.
No, I don't think so.
So, Dr. Currier, I'd love to give you an opportunity to respond to what Dr. Martin said, in particular about the clinical trials. It seems to me that every day there's some new opportunity out there. What would you like to share with our participants?
Yeah, I would like to share just the level of enthusiasm and the number of people who've come together to provide opportunities to evaluate new agents for treatment. It's really the highest priority for a disease that we have no treatment for, both on the inpatient and on the outpatient side. I think that our initial trials that came to UCLA from the NIH and from other industry partners were looking at agents that were available off the shelf, had been developed for other indications, and were being tested for COVID. And now we're starting to see the development of, you know, antivirals, monoclonal antibodies, and other things that may be targeted specifically to this virus. And so I think that there's still a lot of room for improvement in terms of what we have to offer. And we need to think about the whole range of treatments that can be given in pill form to somebody in the outpatient setting, early in disease to prevent progression to hospitalization, as well as for treatment in the hospital. And we've also, I want to just go back to immunity for a second, because we have been looking at using plasma from people who've recovered from infection as a therapeutic. And this was done with influenza and has been done in Ebola. So after somebody recovers from the infection, they come in and they donate plasma, and then that plasma is being now tested as a possible treatment. So it does speak to the concept that we think that immunity is protective. It's just, my point before is we just have a lot more and we need to learn about it. So a lot of options for treatment. Coordinating it has been a challenge, both at the local level and the national level, but there are efforts underway to coordinate these trials and launch master protocols where multiple agents can be compared simultaneously, rather than every study having to, you know, be distinct and separate. But progress is being made, and I'm really hopeful that we'll have better therapeutics moving forward.
You're just getting started. Dr. Garner, it's hard to believe it's only been, what, 5 months since you first learned about what was then called a novel coronavirus, now COVID-19. What would you like to say about going forward with research, or what you see as the future from your perspective with testing?
Yeah, you know, I think what's important, and if everybody saw the cover of the LA Times this morning, it talked about mutations in the virus and what mutations actually mean for both our diagnostics, but also treatment in the course of this outbreak. You know, RNA viruses are known to mutate over time, meaning they change their RNA, and then as they change their RNA, they can change their behavior and how they infect. And so we have a project in my laboratory to start doing something called viral whole genome sequencing, where you take the virus with that extraction method where we extracted the viral RNA. Not only do we run the PCR test to say whether it's there or not, but if it is there, we can actually whole genome sequence that entire virus, look at its individual nucleic acid, and see how it's mutating and changing over time. This type of analysis ends up being very, very important because it helps us predict where the virus is going and what the virus may look like in the fall, in the winter, as we continue this fight against this virus. So, there are some new things that are happening in diagnostic. Again, very research oriented, but we think that will have a large impact if we can include them in our pipeline of diagnostics.
Very good. This has been an incredibly informative discussion. We are coming to the end of our program, but I'd like to give each of you a chance to share some final remarks. And Dr. Currier, I'll start with you.
Thank you. And thank you so much for joining today. I guess my reflection is just on, how incredible the last several months have been for me personally in my career at UCLA and the people that I get to work with every day. I have just seen everyone rise to the occasion and come together in ways that were really unimaginable in the past. And working across departments, across schools, I think that it really shows us that we are all in this together, and only by working together are we going to find the solutions that we need. I do hope Dean Martin made the comment about people entering medical school early on, and it makes me hopeful that we'll see more people choose infectious diseases as a career path. Ours is a field that, we're a small field and not the most popular always, but I hope that it will make people realize how essential it is to have infectious disease divisions and departments to be at the ready when times like this come around.
Absolutely. Or pathologists, right, Dr. Garner? Why don't you say a few final words to our audience?
Sure, absolutely. I really want to thank everyone for calling in. I think one of the most important ways that we all get through this pandemic together is by staying educated. And I think that there's a lot of misinformation out there. Sometimes it's difficult to find a reliable news source. So calling into these types of things, I think, is important because honestly, as important as diagnostic testing is, as important as hospitalized treatment, all of the pieces that we've talked about today, one of the most important things is our individual behavior and our ability to fight this pandemic together. And that is just reliant on us staying educated. And so I'm thankful you all called in today. I'm also thankful for your support. One of the reasons why UCLA Health and my laboratory was able to get off the ground and get in front of this is because we are a laboratory that has the resources to do that. And that's because of the support you've given to UCLA Health. So I just want to thank everybody for calling in, and please continue to contact us to stay in front of what's going to be an ever-changing information environment about this pandemic, but we will all get through it together.
Absolutely. Dr. Kelsey Martin, I'll give you the final word.
Well, thank you. So I also want to thank everybody for spending this past time with us. And I am really honored to share the work of my amazing colleagues at the David Geffen School of Medicine. And I have to vow that, in addition to the amazing work that they've talked about, Dr. Currier is also on the task force that's been put together by Francis Collins, the head of the National Institute of Health. So really, we are playing a very important role nationally across in combating COVID-19. And we talked about my daughter going to medical school and the importance of the future of medicine. And Dr. Garner, in addition to giving birth to the amazing diagnostics at UCLA, is a brand new father. So, again, hope for our future. I think it shows you the level of, real sort of compassion and dedication and caring about the future of humanity. And that's really what's driving all the work that's going on. I do want to express my incredible gratitude to our philanthropic community because it's their generosity that's enabled the work that we've talked about. The support has led to the donation of ventilators, of personal protective equipment. We haven't talked very much about that, but a really important strategy for preventing the spread of disease. They've provided resources for our caregivers. They've enabled a lot of the research that we've talked about, including the work that Dr. Garner really got going so that we would be able to have the sensitive, rapid tests that we now have for PCR detection of the virus. As moved as I personally have been by the innovation and the of our clinical and our scientific community, I've been equally moved by the generosity of everyone who's supported our work, and through the COVID-19 Research and Education Fund, and also through the COVID-19 Patient Care Fund. Today is Giving Tuesday, which is really a global generosity movement that unleashes the power of people and organizations to transform communities in the world, something we need now more than ever. And for me, that really is our collective antidote to the COVID-19 pandemic. You can learn more about giving at uclahealth.org/GTnow. That's uclahealth.org/GTnow. And you can leave your own message of gratitude for our care teams. There's also a special match that I wanted to let you know about, that any gifts given to the COVID-19 Patient Care Fund are going to be matched up to $250,000. And before this conversation, I learned that we were already up to $100,000 in that match. So really, that generosity enables so much progress. And as you've heard, there's a lot of uncertainty going forward. We heard about virus mutations, about the difficulty of getting mass testing, all of the work looking at therapies, the importance of vaccination. The great news is that we have that expertise and we have that knowledge and that community of scientists and physician scientists to enable and to advance that work. And really it's through the partnership with our community that we're able to do so. So I want to wonderful moderator.
Oh, Dr. Martin, thank you so much. I can't tell you how much I appreciate your time. I know you're incredibly busy. So to Dr. Kelsey Martin, Dr. Omai Garner, Dr. Judith Currier, really appreciate your time and your insight today. And we had such wonderful questions from our audience. So if we didn't get to your questions today, we're sorry. We had so many questions, over 100, but we'd like to invite you to visit our website, uclahealth.org/coronavirus. That is uclahealth.org/coronavirus. We've got the most up-to-date information and resources that can help you get some of the answers to your questions. There's an amazing chat bot that we have on our new coronavirus page that I hope you'll check out. And we've got part 2 of our series coming up next Tuesday, May 12th at 11 a.m. Everyone who registered today is going to receive an invitation automatically. So that's the next installment of your COVID-19 questions answered. And in part 2, we'll be joined by UCLA faculty as well as Judy, who is president of UCLA Health and CEO of the UCLA hospital system. So for everyone at UCLA Health, I'm Judy Fortin. I want to say thank you, and we'll see you next week. Bye, everyone.
Bye-bye.